Assalamu alaikum wa rahmatullahi wa barakatuh. Let's continue the second part of our topic, heart sounds and murmurs. So in the first part we have covered the different type of heart sounds, abnormal heart sounds. Today we will talk about heart murmurs. One thing I want to make clear in the first part was I said in the beginning that except to opening snap, all other sounds are diastolic. All other heart sounds are diastolic, S3, S4, and click. But actually, in my mind, it was a tongue slip. Actually, tongue twist. The thing is, a correction to be made there is all other sounds other than ejection clicks, all other heart sounds. Which are those heart sounds? S3, S4, opening snap, okay, split S2. So all these split S2, okay, don't take split S2. So these three sounds are diastolic except to the ejection clicks. Clicks are systolic, okay, that one thing you remember. So what are heart murmurs basically? So murmurs are nothing but abnormal heart sounds, you can say, okay. Murmurs are caused by turbulent blood flow due to high flow rates, forward flow through a narrowed orifice, and backward flow through a leaky wall, incompetent wall, flow through an abnormal communication. So these are the three mechanisms by which murmurs are produced. Number one is forward flow through a narrowed wall, that is nothing but stenosis. Number two is backward flow through an incompetent wall. So that is regurgitation. Number three is flow through an abnormal communication. Example for that is patent ductus arteriosus or ventricular septal defect. Okay. So these are the mechanisms by which murmurs are produced. So there is a scale called as Levine scale to grade the intensity of murmur. So grade 1 is very faint murmur, only heard in ideal conditions. Grade 2 is quiet murmurs but readily heard murmur. Grade 3 is moderately loud, and one thing I want to say here is you can palpate this murmur. You can palpate, but there will be no thrill, without thrill. Palpate with no thrill, that is grade 3. Okay, palpate with no thrill. Grade 4 is loud with thrill. Okay, loud with thrill, that is grade 4. So thrill is 4. Thrill starts after 3. Palpation starts at 3. Grade 5 is very loud and heard with stethoscope partly off the chest. Grade 6 is heard with stethoscope completely off the chest. Okay, that is grade 6. Okay, one important thing you should remember is up to grade 2, usually the murmurs are innocent. So up to this grade 2, our murmurs are considered innocent murmurs if they are asymptomatic and if there are no abnormalities in ECG and chest X-ray. Then those murmurs of grade 2 are considered as benign murmur or innocent murmur. And all murmurs after are equal to grade 3, from 3 to 6 are considered pathologic, and 2D echo is done for those, and if required Dopplers, 2D Doppler also, it is also done. Okay, this is one thing, grading of the murmur. One more basic important thing is point number 1, So during systole, there is closure of atrioventricular valves and opening of uh, pulmonary and aortic valves. So systolic murmurs during systole, which murmurs are heard? So if you know the basics, it is very easy to remember. So because the atrioventricular valves close, so there should be no regurgitation. So AV valves, meaning mitral and tricuspid valves, will have regurgitation. So regurgitant murmurs of the AV valves are produced during systole, and pulmonary and aortic valves are open during systole. So this pulmonary and aortic valves will have stenotic murmurs during systole. Systolic murmurs are nothing but AV regurgitant murmurs and pulmonary and aortic stenotic murmurs. Now number 2 is systolic murmurs. Diastolic murmur. Diastolic murmurs. So what happens during diastole? During diastole, atrioventricular valves will open and pulmonary and aortic valves will close. So during diastole, AV stenotic murmurs will be heard. AV stenotic murmurs will be heard because they will open. So when they are not opening properly, there will be turbulent flow of blood. So there will be murmur. So AV stenotic murmurs, meaning mitral stenosis and tricuspid stenosis, will have murmurs in diastole, and pulmonary and aortic regurgitant murmurs are heard during diastole. Why? Because they are closed. So if there is regurgitation, then there will be murmurs which are produced during diastole. So this is the basic law. Okay, systolic murmurs, in systole you will have AV regurgitant murmurs and aortic stenotic murmurs. In diastole you will have AV stenotic murmurs and aortic regurgitant murmurs. This is the basic rule you should remember. Now we will move forwards. One important point you remember here is diastolic murmurs are rarely louder than grade 4. Remember, all diastolic murmurs are considered pathologic. All diastolic murmurs are considered pathologic irrespective of their intensity, Levine grade, irrespective of their Levine grade. And they are rarely more than grade 4. Now, coming to the systolic murmurs. It can be early systolic. We will divide like this: systolic murmurs, diastolic murmurs, okay, continuous murmurs. Okay, systolic murmur can be early systolic, mid systolic, and late systolic. Diastolic murmur can be, and holosystolic murmur. Diastolic murmur can be early diastolic, mid diastolic murmur, and then continuous murmur, and to and fro murmur. One more is there. So systolic murmur, diastolic murmur, and continuous. Basically three: systolic, diastolic, and continuous murmur. So early systolic murmur begins with S1 and ends in mid systole. So early systolic murmur, remember basic rule. So systolic murmurs, mitral regurgitation. Okay, here just remember, causes acute severe MR will have early systolic murmur. Okay, and TR will have systolic murmur. So early systolic murmur, when there is acute severe mitral regurgitation or tricuspid regurgitation. Okay, just I am playing this audio clip just here. One more time. So what you are noticing in this sound is there is triple sound along with one murmur. Triple sound along with one murmur. So because there is regurgitation, there will be S3 sound also here. Okay, because there is severe mitral regurgitation. If you remember the part one of this lecture, in regurgitation there will be S3 sound because of excessive volume of blood. So there is triple heart sound because there is S3, and there is regurgitation murmur because of there is early systolic murmur because of mitral regurgitation. Okay, now coming to the second thing, that is mid-systolic murmur. This is also known as ejection systolic murmur, ESM, ejection systolic murmur. This begins after S1 and it ends before S2. Begins after S1 and ends before S2. It is crescendo decrescendo shape, means it will increase like this and decrease like this, and this is S1, this is S2, and in this it will be like this. This is S1, this is S2. So this is early systolic murmur and this is ejection systolic murmur. Early systolic and ejection systolic. So what are the causes? Causes can be benign or causes can be pathologic. Remember, ejection systolic murmur can be benign and ejection systolic murmur can be pathologic. So benign ejection systolic murmur you can hear in children's also. Okay, in children's and young adults you can hear this benign, especially in children's. Okay, so that is known as innocent murmur. And pathologic also the difference between these two is ejection systolic murmur will be soft, okay, but the pathologic ejection systolic murmur will be very harsh in quality. So now the causes which mentioned here are the pathologic causes of ejection systolic murmur. So this is systolic murmur, that's why pulmonary and aortic stenosis are the causes. So aortic stenosis murmur, pulmonary stenosis, hypertrophic cardiomyopathy, and flow murmurs. These are benign. These flow murmurs are benign, actually innocent murmurs. They are not harsh. The difference you will hear in the coming audio clips. Okay, so what are flow murmurs? In anemia, hyperdynamic states, in pregnancy, in fever, and thyrotoxicosis also. Thyrotoxicosis, it is also an hyperdynamic state. Pregnancy, anemia, fever, thyrotoxicosis, and children's also you can take. So that is innocent. So just to differentiate, so first I will play the clip of innocent ejection systolic murmur just here. Are you able to appreciate that? One more time. Triple heart sound with murmur. Okay, that is innocent murmur. Okay, benign murmur. Now pathological ejection systolic murmur we will hear. One more time we will hear. So you can hear triple sound here also. So the second heart sound is split. Okay, triple sound you can hear here also, or maybe uh, second heart for associated S4 is will be there in these cases. No, sorry for my mistake. So because there is aortic in all these stenosis like things, no, the ventricle will be hypertrophied, so you will have S4 sound, tenesse, tenesse. Okay, one more time, pathological murmur. So S4, S1, S2 and murmur. Okay, that is about ejection systolic murmur. Now coming to late systolic murmur. Late systolic murmur. This begins in mid systole and continue to S2. Causes is main important causes mitral valve prolapse. And what is this murmur? That is nothing but tensing of the papillary muscle. Tensing of the papillary muscle strings. Okay, that is mitral prolapse. So if this is S1, this is S2, it will be like this. Okay, here there will be a mid-systolic click. And as we have learned in the first part, mid-systolic click is a signature of mitral valve prolapse, and you will have a late diastolic murmur. We will hear that thing. Okay, I am playing the audio. Are you able to hear that? One more time. That's nothing but late systolic murmur. Okay, now coming to pan-systolic murmur. Pan-systolic murmur is heard throughout systole from S1 to S2. Okay, if this is S1, this is S2, it is present throughout. Okay, that is pan-systolic murmur. Okay, and classical causes are mitral regurgitation, tricuspid regurgitation, ventricular septal defect. Ventricular septal defect. Okay, these are the classical causes of pan-systolic murmur. So we will hear that audio clip. Okay. So it seems like you are not getting the S1 S2. You are not able to differentiate S1 and S2 only. It seems like it is encroaching upon the S1 and S2. One more time. That's pansystolic or holosystolic murmur. Now moving forwards towards the diastolic murmurs. So diastolic murmurs are always pathologic. Okay. So they can be early diastolic and mid diastolic. Early diastolic murmurs. So in diastole, regurgitation of aortic and pulmonary valves or stenosis of the atrioventricular valves. So begin immediately after S2. Decrescendo and blowing type murmur. Decrescendo, blowing type. If this is S1 and this is S2, like this. This is early diastolic murmur, and this is classically seen in aortic regurgitation and also in pulmonary regurgitation. That is nothing but Graham-Steele murmur in pulmonary hypertension. So pulmonary regurgitation murmur, early diastolic murmur of pulmonary regurgitation due to pulmonary hypertension is known as Graham-Steele murmur. Okay, we will hear that. Okay. So this is the murmur of aortic regurgitation, early diastolic murmur. Okay. One more time, notice S1 is differentiated, S2 is also you can make out difference, and murmur also you can make out difference. One more time. That's aortic regurgitation murmur. Okay, then coming to, I'll talk about this mid-diastolic murmur. So these diastolic murmurs are also known as rumbling murmur. Diastolic rumbles they are called. Rumble is nothing but if I say in some other words, the sound which comes when the train is running on its track. The sound which comes when the train is running on its track, that is rumbling. Okay, so that type of murmur, rumbling type of diastolic murmurs. Diastolic murmurs are rumbling type. Okay, that is early diastolic. Now mid diastolic, classically you will see in mitral stenosis. Okay, early diastolic in aortic regurgitation, and mid diastolic in mitral stenosis. Other causes include tricuspid stenosis and increased flow across the non-stenotic AV valves. For example, in atrial septal defect also you will have mid-diastolic murmur of tricuspid regurgitation in the tricuspid area in ASD, mitral stenosis. Okay. So let us listen that audio clip. Are you hearing that? One more time. We can easily differentiate. This triple heart sound is there. Okay, mitral stenosis. This triple heart sound is there. That triple heart sound opening snap. One more sound is of opening snap in the diastole. Then there is murmur. S1, S2 opening snap, then murmur. S1, S2 opening snap, then murmur. Like that. One more time. So that's about the mid-diastolic murmur. Okay. Now coming to something called as Austin Flint murmur. You go and watch this murmur. This is not easy to explain. You need to see the anatomy. Okay. This is a functional mid-diastolic rumble in severe aortic regurgitation caused by the regurgitant jet impinging on the mitral wall leaflet. So it is a murmur of aortic regurgitation, not mitral stenosis. Austin, but it is also a mid-diastolic murmur. So differentiating point here is opening snap will be absent. You will not see in Austin Flint murmur. Okay. Now coming to the next, I will explain this one. See here, this diagram, this chart. Okay, you just see. Ejection systolic murmur, nothing but mid-systolic murmur pathologic. It will be like this. Crescendo, decrescendo type. Okay. Crescendo, decrescendo, harsh murmur. Okay. Then pan-systolic murmur of mitral regurgitation or tricuspid regurgitation or ventricular septal defect. It will be like this. Late systolic murmur or late systolic murmur with ejection click. So you see in mitral valve prolapse, it will be like this. Here you will have one click. And early diastolic murmur you see in severe mitral regurgitation. No, as we have learned, acute severe, and also in pulmonary, early diastolic regurgitation. Okay, this is from Davidson actually, and this is from Harrison. Okay, this is nothing but aortic regurgitation. Okay, so it will be like this: early regurgitation murmur. Now Now the last is mid-diastolic murmur. So you see in mitral stenosis, tricuspid stenosis, or flow murmurs. Flow murmurs through the mitral or tricuspid wall, like in ASD, atrial septal defect. So there'll be opening snap, and there'll be continuous murmur in the diastole. So next is continuous murmurs. What is the mechanism? Heart throughout the cardiac cycle due to a continuous pressure gradient, example from artery to vein. From artery to vein. Classical example of this is patent ductus arteriosus. This is also known as machinery murmur. Machinery murmur or AV fistulae. Let's hear the audio. Let's hear the audio clip. So sound is decreasing, increasing, but it is continuous during the systole and diastole, like a machine type. One more time. This also looks like the sound of a moving train on the track. Okay, so you need to differentiate between continuous murmur versus to and fro murmur. To and fro murmur you will see in aortic stenosis with regurgitation. Aortic stenosis plus regurgitation. Regurgitation. Both will be present simultaneously. That is seen in to and fro murmur. But here you see the difference. Continuous murmur will be like this. Increasing, decrease, again increasing, decreasing, like this. But to and fro murmur will have two parts. It will start from the S1 and end before reaching to S2. Then again it will start from S2, like this. Okay, like this. So there will be gap. Here there will be no gap actually. So you need to differentiate between continuous and to and fro murmur. Continuous murmur is present in patens ductus arteriosus, whereas to and fro murmur can be there in combined AR and AS. So that's about in detail. So next is venous hum. It is a benign continuous murmur in the neck from the jugular vein flow. Jugular vein flow disappears with light jugular compression or turning the head. So you auscultate yourself and you hear the murmur. That is murmur is said in with respect to walls, but if it occurs in veins, that is called as hum, venous hum. Okay. Dynamic auscultation is one thing. What is this dynamic auscultation? It is nothing but maneuvers. Some maneuvers alter the preload, afterload, and contractility of the heart, and hence alter the intensity of the murmur. So that is known as dynamic auscultation. So as you know, in inspiration, there will be increased right ventricular return and right ventricular volume. So right sided murmurs will be increased and left sided murmur intensity will be decreased. In standing position or in Valsalva, there will be decreased venous return, decreased preload. The murmurs of hypertrophic cardiomyopathy and mitral valve prolapse will increase in this case. Okay, when there is decreased venous return. And the murmurs of ASMR. So because during there is less blood in the less blood in the left ventricle, so low end diastolic volume, so intensity of murmur will be reduced. So ASMR VSD you will have decreased murmur. Squatting or leg raise, again you are increasing the preload also and you are increasing the afterload. Afterload is nothing but the systemic vascular resistance. Preload is nothing but the venous return. So in that case, hyper HOCM murmur and MVB murmur will decrease. And okay, just remember these highlighted things. Hand grip or vasoconstrictors, again you are increasing the afterload. Okay, and these are the result. Okay, amyl nitrate is a vasodilator, you are decreasing the afterload, so this murmur will increase. Okay, and one more thing is post premature ventricular contraction, nothing but the premature ventricular beat, VPCs, ventricular premature contractions, extra systoles. So they increase the contractility because there will be a pause, no, after that PVC. There will be a pause, that pause causes increased contraction in the next heartbeat. So that will increase the murmur of aortic stenosis and hypertrophic cardiomyopathy. So that's about the dynamic auscultation. Now coming to the how do you approach and how you diagnose. Take the history and context. Associated symptoms, you ask whether there is chest pain, whether there is dyspnea, whether there is palpitation, whether there is syncope. You will have some clue. Whether there is associated fever, then suspect endocarditis, infection of the damaged wall. Whether you ask history of rheumatic fever or MI, because these can be the cause of valvular abnormality. Valvular abnormality. Rheumatic fever is the most, rheumatic heart disease is the most common cause of valvular abnormality. Okay, remember this point. And in physical examination, what you will focus in physical examination? See the JVP. This will indicate the pressure of right atrium. Pressure in the right atrium. Okay. If it is raised, then pressure in the right atrium is raised. See peripheral signs of endocarditis, infection of the. So you're focusing on the cause of the valvular abnormality and associated some whether it is causing some complication because of that valvular abnormality, and whether that wall is infected or not. Endocarditis, and you will palpate the pulse. Okay, slow rising in aortic stenosis and collapsing in aortic regurgitation. Chest palpation is important in murmurs. Whether you can see thrills and heaves. Okay. So whenever you are examining a patient, the Davidson always starting a topic, no, he will give a diagram like this. This is the hand, no, he will give like this. Examine the fingers, examine the hands, palpate the pulse, check the BP, then come to forehead, CNS, then eyes, then mouth, okay, neck, what you will see. After neck, then chest, then abdomen, okay, then pedal edema. So you should move like this, like a circle, which the Davidson says always in any examination you should move like this. So what is the investigation if you detect an abnormality, okay, any murmur? So the investigation is echocardiography. Okay. Other test which you should do is ECG. It can show hypertrophy or ischemia. Chest X-ray, it can show cardiac size, whether it is enlarged or pulmonary congestion. Okay. Cardiac MRI, CT for complex anatomy, catheterization of coronary anatomy pre-surgery. So that's about the history, physical examination, or primary investigations, ECG and chest X-ray. Okay, history examination, ECG, chest X-ray, that all you will do. Okay, how do you? This is the final flow chart, algorithmic approach to a murmur. So when you detect a murmur, first you classify it as systolic murmur, diastolic murmur, or continuous murmur. If it is systolic and it is mid-systolic murmur and the grade is less than 2, I said it can be innocent murmur. So if it is symptomatic or if there is abnormal ECG or chest X-ray, then you do echocardiography. Or if it is symptomatic here or there are signs of cardiac disease in ECG and X-ray, you will do echocardiography. If it is asymptomatic and there are no signs of cardiac disease in ECG and X-ray, you will not do further workup. You will discharge the patient and you will say it has a innocent murmur. Other murmurs except to this, like early systolic murmur, mid-systolic murmur of grade 3 or more, late systolic murmur or pan-systolic murmur, all these murmurs are considered pathologic and you should evaluate by echocardiography. All the diastolic murmurs are considered pathologic no need for grading, do 2D echo. Continuous murmur, do 2D echo. Okay, continuous murmur can be due to a patent ductus arteriosus, or it can be due to venous hum or memory souffle, which you during pregnancy you will hear this, no? So after 2D echo, the next investigation is Doppler 2D echo and cardiac MRI catheterization if appropriate. Okay, that's about the approach to a patient with murmur. So with this, we finish our topic of heart sounds and murmur. Thank you for your listening.